Hello, good evening, everyone. CCI Life members, fellow pulmonologists, other medical professionals. Good morning and good afternoon to people who have logged from other parts of the globe. Chest Council of India wishes all of you a wonderful Merry Christmas and a very memorable year ending holiday with your family and near and dear ones. Today is technically the last CCI webinar of 2025, and as usual, we have tried to bring a topic that has never been touched before. The name of this topic is hyperhidrosis, where sweating becomes an issue. All of you may wonder, what is hyperhidrosis doing in a pulmonary webinar? But hyperhidrosis is something doctors of various specialties face at different points of time. It may often be in family member, friend circle, and the treatment of it involves via the thorax. So that is why, although challenging, although not being directly related to us, we have taken up this challenge so that all of you become super comfortable when you encounter such things in your real life. And we have the best people in India who are tackling this condition. Our panelists are Dr. Nazia Nousheen Siddiqa. She is a pulmonologist as well as a dermatologist from Hyderabad, Telangana. We have Dr. Manjunath Bale, who is a minimum invasive thoracic robotic oncosurgeon. And we have none other than our webinar coordinator gracing the occasion today, Dr. Vijay Kumar Chennamchetty. Dr. Vijay Chennamchetty does not need any introduction in this audience. He is the one, the brainchild behind all these webinars. He ensures that all these webinars are flawless. Now, before I would want to begin, we have a very important announcement. If the technical team can kindly play that slide. Of you for our 7th CCI Con in the land of the rising sun in India, Guwahati, 25th to 27th September 2026. Please save the date. Please do not keep any engagement that time. And please be with us for a one-to-one physical get-together on 25th to 27th September at CCI Con, Guwahati. Now I would want to invite our two speakers, first Dr. Nazia and then Dr. Manjuna, who will give their take on this very important talk, hyperhidrosis.
Today my topic is hyperhidrosis, the pathophysiology and clinical features. Hyperhidrosis, by definition, is disorder of eccrine sweat glands. There is excessive production of sweat due to overstimulation of cholinergic receptors on eccrine glands that is more than is required for thermoregulation. Defined gravimetrically as more than 2 standard deviation above the mean values of sweat secretion for a normal population in various sites. In palmar areas, more than 50 milligrams. In plantar, also 50 milligrams, and whereas in axillary areas, more than 150 milligrams per minute per square meter. Facial, also 50 milligrams. So why does this hyperhidrosis matter? Primary hyperhidrosis affects 2 to 3% of the global population and equal among men and women. And most commonly in localized disease beginning in childhood, adolescence and young adults it is peaking. Sometimes it can present also after 60 years of age and prompting secondary evaluation. This is the important concern for us today, because if you see sudden hyperhidrosis, then there has to be prompt evaluation for secondary causes of hyperhidrosis. And all races are affected, though palmoplantar hyperhidrosis is more common in Japanese populations. The disease burden and there is marked impairment in quality of life, often comparable or exceeding that seen in chronic inflammatory skin disease like psoriasis. And the condition is frequently underdiagnosed and undertreated, making its early recognition and appropriate management it is clinically important. Let us now understand the eccrine sweat glands. The sweating is a reflex autonomic function mediated by sympathetic nervous system via cholinergic neurons, and sweat is produced predominantly by eccrine sweat glands, the primary role of which is thermoregulation through evaporative heat loss. Eccrine sweat glands are distributed over most of the body with high density on palms, soles, forehead and upper limbs, and a healthy adult can produce more than 0.5 liters of sweat per hour composed of 99% of water. In normal physiology of sweating, whenever the temperature rises, it causes the hypothalamus sensing the rise in temperature. It sends signals via the nervous system. This causes the sweat glands receiving signal and secreting excessive amount of sweat. And also the blood vessels receive signal and dilate. This causes homeostasis and internal body temperature decreases, comes back to normal body temperature of 36 to 38 degrees centigrade. In normal physiology of sweating, it is produced as a secretory coil, the acinus. There is a coil as an isotonic fluid under sympathetic cholinergic stimulation. As the sweat moves up the duct, sodium and chloride are actively reabsorbed because of the ENA sodium channels and CFTR channels, while water is not reabsorbed. This converts primary sweat into hypotonic final sweat, which reaches the skin surface for evaporative cooling, which regulates the temperature. These are the sodium ENAC receptors you can see here and CFTR receptors. What is the pathophysiology of hyperhidrosis? It's a control system problem, not a gland problem. So basically the control is central. The primary hyperhidrosis is caused by hyperactivity of the sympathetic cholinergic pathways, not by an increase in the number or size of the glands. The eccrine sweat glands are structurally normal but show an exaggerated response to emotional or thermal stimuli. There is a lower threshold for sweat initiation and increased pseudomotor nerve firing. Dysfunction is believed to be centrally mediated hypothalamic autonomic dysregulation. It results in excessive localized and bilateral sweating independent of thermoregulatory needs. Coming to classification of hyperhidrosis, on the basis of the cause, it can be primary or secondary, and on the basis of laterality, it can be unilateral or bilateral, and according to anatomical location, focal or generalized hyperhidrosis. The secondary hyperhidrosis is a cause of concern for us. Hyperhidrosis, in primary hyperhidrosis, there is no cause elicited, can be localized or generalized. More often it is localized, and main stimulus is cortical. The glands are normal here and medical conditions are not associated. Whereas in secondary hyperhidrosis, some cause will be present, can be localized or generalized. Generalized is more common. Stimulus can be cortical, hypothalamic, spinal or local. And here the glands are involved and medical conditions are associated. So we have to think about medical conditions, what can be associated with this secondary hyperhidrosis. The primary focal hyperhidrosis defined as excessive sweating in localized areas like palms, soles, axilla, groins, and is not associated with systemic disorders. The most common types of hyperhidrosis is primary, and it arises from increased cortical stimulation and occurs only during waking hours like diurnal pattern, and the family history is also present up to 60 to 80% of patients. The diagnostic criteria for this localized focal visible excessive sweating for at least 6 months with no apparent secondary causes, with at least 2 of the following like bilateral or relatively symmetric, impairment of daily activities like writing, and there are a lot of sweating from the hands, at least 1 episode per week, and the age of onset is less than 25 years and positive family history presents, and it is not present during sleeping time. In axillary hyperhidrosis, the second most common form begins in post-pubertal age. Up to 25% of people will have coexisting palmar hyperhidrosis also. Sweating is most commonly phasic, not as continuous, gets worse in hot and humid environments. Axillary bromhidrosis, that is bad smell, is not present here. Craniofacial hyperhidrosis on the scalp and face, generally phasic and occurs in middle age. It may get triggered by heat, exercise, sometimes eating certain foods also. It may be more persistent and usually presents at a later age than palmoplantar hyperhidrosis. The entire face and scalp affected and may be completely soaked with sweat. The important one more cause of hyperhidrosis is gustatory hyperhidrosis. It can be physiological or pathological. The physiological gustatory sweating, localized sweating on the lips, forehead, scalp and nose in a symmetrical manner. It is triggered by eating hot spicy foods, citrus foods and alcohol. The taste buds get stimulated via glossopharyngeal nerve. and this causes the medulla oblongata, and it is also called medullary hyperhidrosis, leads to salivation and sweating. Faint erythema is also seen on the faces and no other local signs or symptoms are present. The pathological gustatory sweating, it's a disorder arises when disrupted nerves for sweat gland aberrantly connected to nerves. The sweat glands which are connected to salivary glands are affected here. The deviate is salivation. Thus, salivary stimulation elicits sweating here. Important cause is freeze syndrome. This freeze syndrome is for following trauma or surgery in the region of parotid gland. Sweating occurs along with auriculotemporal nerve distribution. Cauda tympani syndrome due to surgery or injury in and around the submandibular area. The salivary stimuli to the submandibular gland induces sweating along with lower jawline and chin. Sympathetic trunk injury, carcinoma lung, mesothelioma, thyroidectomy are the causes of this sympathetic trunk injury. Cholinergic fibers from the vagus nerve merge into adjacent sympathetic tracts during the healing process, resulting in gustatory hyperhidrosis with sweating on the face, neck and portions of the trunk and upper extremities. Sympathetic hyperactivity following encephalitis and syringomyelia can be the pathology. Here, peripheral autonomic or sensory neuropathy as in diabetes or herpes zoster of the preauricular area. Reader syndrome is nothing but excessive supraorbital sweating like lacrimal sweating. Now coming to secondary hyperhidrosis, it is caused or by associated with another systemic disorders, can be generalized or localized to palmoplantar, axillary or other cutaneous sites. Divided on the basis of source of the neural impulse driving the response, like it can be cortical, hypothalamic, medullary, spinal or local. When it comes to hypothalamic hyperhidrosis, the causes are direct hypothalamic stimuli or elevated body temperature. It can be because of infections as in tuberculosis, brucellosis, malaria and CNS at SABE, acute febrile illness. Metabolic or endocrine causes like hyperthyroidism, acromegaly, hypoglycemia, dumping syndrome and menopause. Tumors like lymphomas, pheomochromocytoma, carcinoid tumors, leukemias and mesotheliomas. Certain drugs which also cause hypothalamic hyperhidrosis like SSRIs, antipsychotics, dopamine agonists, anticholinesterases and anti-glaucoma drugs. Vasomotor causes can be myocardial infarction, congestive heart failure, acrocyanosis, Raynaud's phenomenon, symmetric lividity of the palms and soles. Coming to the drugs which can cause hyperhidrosis like SSRI, like fluoxetine, duloxetine, fluoxamine, citalopram, escitalopram. The serotonergic effect on the spinal cord and hypothalamus causes hyperhidrosis. Other CNS drugs like amitriptyline, nortriptyline, imipramine, norepinephrine reuptake inhibition happens and this causes hyperhidrosis. Drugs like opioids, morphine, methadone, fentanyl also cause histamine release and this causes hyperhidrosis. Anticholinesterases like pyridostigmine, increased acetylcholine causes hyperhidrosis. Anti-glaucoma drugs like pilocarpine, physostigmine causes increased acetylcholine and this causes hyperhidrosis. And this comes about the clinical features and causes of hyperhidrosis. Different drugs causing hyperhidrosis like we can see here. Tricyclic antidepressants and SSRIs, opioids, anticholinesterases, anti-glaucoma drugs. And coming to the next slide, compensatory hyperhidrosis. Sweat glands in one area become hyperactive to compensate for the hyperanhidrosis elsewhere in the body. Like in miliaria, non-functioning trunk glands lead to compensatory face sweating. In diabetes mellitus also, neuropathy in the legs causing compensatory face and neck excessive sweating. And post-sympathectomy, cervicothoracic sympathectomy causes trunk hyperhidrosis. Spinal sweating, spinal cord injury or disease, for example, tabes dorsalis, syringomyelia disrupts the sweating reflex. Abnormal segmental sweating and autonomic sensory and motor alterations. Lack of sweat response to thermal stimulation below injury level. These are all the causes and pathophysiology about sweating. Now the next speaker will take up. Thank you.
Good evening, everyone. Hyperhidrosis is a very common clinical condition. It affects about 1% of the population. It's basically a pathological condition of excessive sweating in amounts greater than the physiological sweating which happens to regulate the temperature. Basically, normally we all sweat to maintain a thermoregulatory temperature, but in these patients there is excessive sweating. There is a dysfunction in the thermoregulatory capacity of the and basically the sympathetic component is overactive, and there is a huge disproportionate from the trigger. For example, what happens is, and whenever we have a trigger for sweating, we sweat and we stop. But in patients with hyperhidrosis, the trigger starts and then there is no stop there, and then it keeps on sweating. You can see the videos here. The sweating is so severe that the whole palms and soles become so wet that basically the patient has so many issues because of that. And when patient have such kind of sweating which affects their daily life, they come to us for evaluation, and there is a severity score which we follow to see how much sweating happens in each patient and whether it is whether any intervention is needed or not needed. For example, this is a disease severity score which you use. It is basically my sweating is never noticeable and never interferes with my daily activities. My sweating is tolerable, but sometimes it interferes with my daily activities. My sweating is barely tolerable and frequently interferes in my daily life, and my sweating is intolerable. So these are the grades. Now, once we know the grades, we will see who are the patients who actually need treatment. There are a lot of patients who come to us with some symptoms which are very mild. We neglect them. We say them, okay, this is not, there's no need for you to undergo any procedure. But there are some patients who have life changing sequences. I will never call it life threatening, but these symptoms can be life changing. I will tell you a few examples. For example, there is a boy who goes to a 10th standard exam and he misses out on writing few main answers because his palms are sweating excessively, and he wastes time in wiping his hands and cleaning his hands dry. Or, for example, if he writes a paper and the whole paper gets wet and then the main points are gone, then maybe his life is changed forever. I have a patient. She came to me. She was an MBBS graduate. She went to write the NEET exam, and because she was not able to do the biometry properly, she lost 15 minutes of her exam. 15 minutes in a NEET exam, and it changed her course of life. She had to take pathology because there was no other seat she was getting apart from that because of her poor rank. There's a family who needed who needed marital counseling because of the excessive sweating of one of the partners. There was one funny incident where one of the patient had to register her house to her husband's name because she was not able to do the biometric when they went for the registration of the house. So there are so many common problems which we face, which these patients face, which goes unnoticed. One of the most commonest problem which people have are social isolation. Basically, patients have so much sweating that they don't like to shake hands with another person. This, especially in the corporate world of today, is an important asset for a guy to be confident, to show up, shake hand, give you a strong shake hand. But if your palms are always sweating, how will you shake hands? You are mostly worried about how will you feel about my sweaty palms. So these are the patients who actually need some kind of an intervention. Now, when we look at the ideal candidates, it is basically early onset disease, younger patients, appropriate BMI, report no sweating during sleep, and no other significant comorbidities. And the one important aspect for a surgeon to look forward when they do a surgery for hyperhidrosis is what is the heart rate. If the heart rate is 55 or less, these are not candidates for sympathectomy, because you may do a surgery for them, their heart rate might go just by 5 less, and then the heart rate will be 50, 45, 50, and then they'll have chronic other problems. They'll become they become incapable of doing any stress response. So one has to be very, very careful when doing a selection of these patients. And as I said about the hyperhidrosis disease severity score, 3 or more are suitable for surgery. Now, as I told you, there is a profound effect on the quality of life, social, economical, emotional, psychological, all kinds of important things are there. It is actually it is akin to some chronic conditions like psoriasis, like CKD, where patients suffer from so many other problems. Hyperhidrosis has been considered akin to those conditions. Now, When we talk about surgical management, my dermatology colleague has told about the medical management. Now I'll talk about the surgical management. Surgical management of sympathectomy for hyperhidrosis has been sympathectomy. One is surprised when I look back at the data. I was surprised that the surgery was done the first time in 1920. So the idea of doing a sympathectomy for hyperhidrosis is not a new one which is arrived, which is not come in the last decade or so. It has been there since 1920, and then it was thoracoscopically done in 1942. So you can understand it's been a very long the history of it. So now there are a lot of modifications within the technique. So this is a small video I would like to play. I'm not sure whether the video is playing. So this is the position of the patient. We make him almost like a sitting position with an LMA in situ. We don't place any tubes, no endotracheal tube, no arterial line, no double lumen, no Foley's catheter, no Ryle's tube, nothing. So we do it with a combination of LMA and local anesthesia. This is the local anesthesia injected. You can see that is the nerve which is there. You can see, and then once the nerve is identified, then we apply clips at only one level. Now I'll tell you the concept of doing one level and multiple levels. I think some of my surgical colleagues may have an argument with me about doing multiple levels or completely taking the nerve off. We have been following the concept of clipping the nerves for quite some time now, and these are the level of interruptions which we prefer. For example, if there's a palmar hydrosis, it is R3 or R4. Now we don't use the words T3 or T4. It is basically on the rib on which we are cutting. It is either fourth rib or third rib. Basically, the higher you go, the closer you go to the stellate ganglion, the chances of you having more drier hands are more, but also the chances of compensatory hyperhidrosis are also more. So preferably if it's palmoplantar, I would do an R4. I can say I can make your hands dry. I'm not sure of your soles, but at least you won't have compensatory hyperhidrosis. If I do an R3, R4, you'll be having more drier and hands and soles, no doubt, but you'll have more compensatory hyperhidrosis. So someone has to take the bullet and go for the minimum and enjoy the benefits of the surgery. Now, isolated axillary, we are not performing surgery because I think with all the dermatological interventions, it can be taken care. Isolated craniofacial, we are doing surgery with very good results. We have done quite a few now with isolated facial. They're doing well. Palmo axillary or palmoplantar axillary, R4 or R3 based on that. If it's an axillary, I would do with the palmar, I do it at R3. If it's palmoplantar, then R4. I don't do R5 because the compensatory hyperhidrosis are significantly higher. Now I'll come to our own analysis of the data. We did about 85 cases in the last 3 years, and predominantly males, young males. You can see the mean age is only 24 years. That means it's mostly due to patients in younger generation. And we are very careful in choosing patients who have any comorbidities, especially diabetes. You have to be sure that it's not an uncontrolled diabetes if you have to choose one. Luckily, we have not come across many patients with comorbidities, and duration of illness has been mostly from childhood, but we have seen some patients who have come in adulthood who have had symptoms on late onset. And you can see a lot of interventional failures have happened. The dermatological interventions have taken care in about, say, 50% of the patients had some dermatological intervention, including Botox, including creams, antiphorosis. A lot of interventions have been done. Now, in our this thing, we have mostly palmoplantar variant, which is about 71% of 71 cases. 10 cases have palmoplantar plus axillary, and only 4 had pure craniofacial. But we were initially worried about doing craniofacial isolated because of the symptoms of worry of honors. But now we have started doing, and we have a decent result. We can actually we can say that it is safer to do, and there is no issue with that. The other thing is, what is the surgical data? How long do it take to do a surgery? It's like, say, the average surgical time is 45 minutes. And we check the temperature of the hands when we do the surgery. An elevation of 1 degree of hand temperature is indicated to be will suggest you of a complete interruption. Now, Any of the patients needed intubation? Nil. We didn't have to convert from a non-intubated to an intubated in any of these cases. One patient required ICD because there was some moves and I was a little skeptical to send the patient without the ICD. I placed an ICD, and we generally do daycare, but because of the insurance policy, we admit some of the patients. Nearly about, we have a lot of patients for insurance, so we keep them the night and then send them next morning, because purely because of the insurance, not because of any medical reasons. So now, when we do the surgery, one of the most important thing is, what are the problems? Is there any problem? Is there anything we worry about? Yes, there are some symptoms which can be bothersome. One patient had gustatory hyperhidrosis. Now, it's a little tough for me to explain the pathophysiology behind it, but he says whenever he has spicy food, he starts sweating on the face. It's very, very rare to happen, but it is there with one of my patients. He is curtailed a little. He's made a little bit of lifestyle modifications, which has helped him to overcome this problem. Now, excessive dry hands is seen in 3 patients where patients are actually using moisturizer 24/7. It's a bothersome symptom. Then we also have compensatory hyperhidrosis in 2 of the patients. They have mostly in the back, which is, and the thighs, which is self-limiting. So that is okay. One of our patients needs a redo surgery because he has partial relief of symptoms, and 3 patients we had where palmar sweating was less, but it was not completely relieved, and luckily we didn't have any wound complications or pneumothorax till now. So this is about our outcome. Now the question always someone asked me is, oh, my child is very young, should I get it done or not? So these are the symptoms where your young child, even he is young, is not too young to get the surgery done. Like holding a pen has become a difficulty, keeping a paper dry is a difficulty, gripping a hand bar on the cycle is a difficulty, manipulating a computer mouse becomes difficulty, sociophobia, anxiety, depression. In teenage, in today's era where social media has influenced most of our lives, I think if we have a child who has sweating and he's having social phobia, he has anxiety, I think he needs to be addressed. And now the most important thing is, I have seen one of those patients, like this is a very interesting story where a mother came to me, and she was a young lady about 35. She got the surgery done, she went home, and she came for the visit. And I asked her, why did you decide so late? I mean, what was it now that you are getting the surgery done? She told me that, no, my son has started sweating again like me, so I want to see whether this treatment works or not. So I am putting myself under the knife so that I'm sure that my son gets the best of treatment. So, these kind of stories really make sympathectomy not just a surgery, it's more of a life changing event. So, the take home message is, sympathectomy for hyperhidrosis is a safe procedure. Careful selection of the patients is important. Identification of the correct level of interruption is very important. Higher the level, more the chances of drier hands, but also more the chances of compensatory hyperhidrosis, as well as chances of
Thank you, Dr. Nazia. Thank you, Dr. Manjunath. Although I am pretending to be the moderator today, and in the last 3 or 5 days, I was trying to read a lot about this disease, which was perhaps optional for me during my MBBS. But after listening to both of your lectures, at least I will be able to give the right direction to people who may approach me with this condition. We have some questions, and I'm very grateful that even on Christmas, there are people who have logged in live, who are watching us, who are trying to take back something new for their day to day profession. We have a question from Dr. Soni Singh, who is from Jammu, and I would request Dr. Vijay sir that the question is, why people are sweating more when they are drinking and eating more spicy food? Dr. Vijay sir, your take on this.
Probably, okay, probably it's a reflex phenomenon. Okay, since Nazia has told very clearly about the pathophysiological mechanism, it is somewhere it is related to some gut and then the central reflex. I request Nazia to answer this question to be very precise.
Yeah, thank you, sir. This is a central phenomenon because when there are spicy, it gives stimulus, it gives a message to the brain, something like increase in temperature. So during this process, the secretions increase, the sweat as well as salivation is increased. So that sweating increases in certain individuals after taking spicy foods. It stimulus to the cortical stimulus and hypothalamic stimulus causes increased salivation as well as sweating.
Thank you. Thank you. I am sure your question is answered. A question for you, Dr. Nazia,
Yeah.
that often primary or idiopathic is very difficult, but as clinicians, we are more concerned about secondary causes because secondary causes are something where we can at least give the patient an answer that, oh, you had this disease, perhaps this caused hydrosis. So, although you have mentioned in your talk, once for the live audience, could you please enumerate what were the diseases that caused secondary hyperhidrosis?
Yeah. Like we know, the primary hyperhidrosis occurs below 25 years of age, and the patient knows since childhood. When secondary hyperhidrosis comes into picture, the patient suddenly starts seeing hyperhidrosis. We have to rule out certain medical conditions, something like diabetes, tuberculosis, any other diseases, any other infections. It can be endocarditis. I mean, all the infections can have a role because the temperature alteration is there. So we have to note infections, other conditions which are causing, any drugs they are taking which is causing their hyperhidrosis, and all these certain drugs are also causing tricyclic antidepressants. And thyroid is an important thing. We have to rule out hyperthyroidism and any other malignancies, pheochromocytoma. All these conditions can cause. So it is a time to evaluate the patient for all these medical conditions which can cause secondary hyperhidrosis. Even
When you mention this malignancies,
Hmm.
would we want to call this a paraneoplastic syndrome? Any of our panelists, can hyperhidrosis be part of a paraneoplastic syndrome?
Yes, in pheochromocytoma, it can be a paraneoplastic syndrome, and other in even carcinoma lung also it can have a symptoms of hyperhidrosis can be present.
I just received a message from our founder trustee, Dr. N.H. Krishna sir, that when all the three panelists here are from Hyderabad, Dr. Vijay, Dr. Nazia, Dr. Manjunath, we can name our webinar today as Hyderabadi Hyperhidrosis. So that's a wonderful comment. Thank you, sir, for your guidance always. Dr. Manjunath,
Yes.
once upon a time, perhaps the decision to operate was a consent from the family and the willingness of the surgeon and the availability of an OT with the assistant. But
Yes.
nowadays, thanks to insurance, thanks to social media, there are almost cast iron guidelines that where to operate, not to operate. So, very brief briefing for our crowd that please elaborate when to operate these patients, Dr. Manjunath.
As I said, any patient whose lifestyle has been changed because of hyperhidrosis, because of excessive sweating, they deserve a chance at surgery. Now, there is always a question of insurance. Insurance has most of the times, earlier when we used to send for an insurance, they used to say it's a cosmetic reason and we cannot allow it. This had happened to us many a times. Then we were actually able to convince them that this is not a cosmetic problem, this is a quality of life problem. The moment we started writing that as a explanation to our query, most of the insurance policies agree to it. Now, young patient who is having a primary hyperhidrosis of hyperhidrosis disease severity score of 3 or more is a candidate for surgery. Now, one of the important aspect is patient should not be sweating in the night. That means it's one of the things where we say, okay, patient has no sweating in the night. That means it's a primary hyperhidrosis. Another important aspect to consider is heart rate of the patient. If the heart rate of the patient is less, we should not do them because they can go into failure and they may require a permanent pacemaker after doing a sympathectomy. This is one of the important consideration we should keep in our minds. Otherwise, it's a very safe procedure. So it can be offered to any patient who has a quality of life change because of this.
You gave me a wonderful answer. Now that we are at the end of the year in our city, every alternate day we are having get together of some or the other hospital, and I don't know why all of them are inviting me. So last get together, one cardiologist was telling me that tell me some surgeries which can lead to pacemaker condition. So I got one answer. Maybe tomorrow's party, if me and he are both invited, I will tell this thing that I got a surgery which can lead to a pacemaker condition. Thank you, Dr. Manjunath. That's a wonderful answer. We have a comment from Dr. Praveen, who is from Hyderabad, Telangana. I suddenly get sweating on my hands and legs. Why does this happen and how can I control and prevent it? Any of our panelists, would you want to volunteer?
Oh, first, I request Nazia to answer, then I'll answer.
Sudden getting of sweating can be because of anxiety, hypotension, hypoglycemia, all these things. And we cannot label it as directly hyperhidrosis because it has to be an episode every week. When once in a while cannot be hyperhidrosis, and during daytime only. So most maybe because of anxiety or any other conditions you are getting hyperhidrosis or hypertension. And how to manage that one can be in medical management of hyperhidrosis is with topical applications or tablets like oxybutynin and glycopyrrolate, and also we give injection botulinum toxin if the patient is getting recurrent hyperhidrosis in the palms and soles and also in the axilla. We usually prefer giving botulinum toxin before we refer the patient to a surgery, and though definitely they require repeated injections, but some patients are apprehensive about going for surgery, so we give injection botulinum toxin on the palms as well as in the axilla. So I think I have.
So I agree partly with Dr. Nazia, but what clinically is very much beneficial for the patient is probably SOS glycopyrrolate can be given. So which would be helping them to overcome, because if someone is, as Dr. Manju was mentioning very clearly, if the patient is not having too much of severity of the problems, then probably he is going to a party, then where he is going to interact with hundreds of people or many people or important official meeting, then ask them to have a glycopyrrolate and then allow them to overcome the hyperhidrosis. That's one thing. But if it is a severe kind of thing, okay, it is not going to work. That's one thing. And second thing is my question to Dr. Manju. Manju, that's a wonderful lecture. I thoroughly enjoyed. But my question to you is, you out of the adverse events that you have mentioned, you clearly mentioned, dry hands, 3 patients, probably on what is the percentage of patients that who failed on the surgery? You haven't mentioned.
No, I mentioned it, sir. I mentioned it. I'm sorry, I think you missed it out. We had 3 patients who had no relief in symptoms. So one of them wants a resurgery. I mentioned it.
Okay.
Yes, sir. Right. So say we generally say about 5% of the patients will have partial relief or no relief. I always tell this to all my patients, sir.
Right. So, but what is very, very interesting in your presentation is NIVAX is one thing, okay, where that is the latest technology where these patients can just walk away probably after 4 hours or 5 hours after observation in the post-op period. If they are not, they don't belong to insurance category, we can send them on the same day evening. Okay, perfectly.
Yes.
Right.
Yes, sir. The cost factor becomes a major thing, sir, because we can cut down the cost significantly if you're sending on the same day, sir.
Yes, yes.
Yes. Sir.
And of course, that is helpful for surgeon as well.
Yes, sir.
Thank you. Thank you. We have another comment from Maharashtra, Dr. Milind Chaudhary for Solapur. As we had discussed that tuberculosis was a cause of secondary hyperhidrosis. So is it axillary lymph node TB or something else? And how effective is anti-cox therapy in eradicating hyperhidrosis? Definitely anti-cox eradicates the tubercle bacilli, but how effective is anti-cox in eradicating the hyperhidrosis also?
But to be precise, Dr. Atri, okay, there is no such data that is available to give a valid comment in an academic webinar. Okay, I don't think AKT is effective in management of hyperhidrosis, and even if it is secondary, from infections, granulomatous infections like maybe sarcoid or tuberculosis kind of thing. I don't, there is no data to comment openly that AKT is going to be some beneficial. And my comments is probably these patients, as both of our speakers very clearly mentioned, that they will have a lot of anxiety issues, mood issues kind of thing. So they need to manage this by proper relaxing therapies like maybe music or meditation or some form of yoga and some form of example. If they want to go and try to interact a interview kind of scenario, they should face enough trials well in advance so that they gain confidence. Probably again to come back to the base, a glycopyrrolate would raise their confidence levels.
Sir, I want to add one more point here, sir.
Please, Manju.
Sir, any patient who is having too much of an anxiety issue, we ask them to meet a psychiatrist before we do the surgery, sir. This is one of the, I actually missed out this point. It is very important to have a psychiatric evaluation before we plan surgery for these patients. Because if they don't respond well to surgery, then they can create havoc in our life. So it's better we send them to psychiatric evaluation before the surgery is planned, sir.
Point I will add about tuberculosis, when as we see in tuberculosis or any other infections like brucellosis, malaria, the hyperhidrosis here is because of temperature mechanism. The patient is febrile. So when he is responding for the ATT, so we can expect as his general health improves, so the temperature baseline sets and the cause of hyperhidrosis automatically gets relieved. So that's what we see in our patients, that the basic cause is because of the cortisol. During daytime they have cortisol and they do not sweat, and they have night sweats, more of night sweats. When the general well-being of the patient and he gets negative and AFB negative, we can expect that he'll have a mild improvement, definitely improvement in this hyperhidrosis.
I found two wonderful messages over here for our audience. One is interdepartmental cross coordination. You need a dermatologist, physician, maybe a diabetes guy, psychiatrist, anesthetist, and surgeon. That's something wonderful. Pulmonologist, definitely.
No, one more. Sleep physician. Okay. We have had a case of hyperhidrosis that is because of upper airway resistance syndrome. Okay. So that after addressing upper airway resistance syndrome, patient became better. So that's also an important cause.
That's something wonderful. And second message I got was anxiety. Tuberculosis causes lots of anxiety. Perhaps that is something we often fail to address in our day-to-day practice. So next time, whenever we see this tuberculosis patient, we should make it a habit to talk about anxiety to the patient and the family members. Tuberculosis, there is still a lot of stigma, taboo, long duration of medicine, lots of restrictions. You can't do lots of socialization. Then again, infectiousness, adverse effect of the medicine, hemoptysis causing anxiety. I got a patient, young guy. Even after treatment, after 15 days, he came back to me with hemoptysis, further anxiety. So whenever we are talking about tuberculosis, we must address this anxiety. I just now got a message from Dr. Krishna sir that even on Christmas, we have a live 1,821 live logins. That's a phenomenal number. More than 1,800 people are watching us live on Christmas. And this is the support of the audience that pushes us. So we are very grateful to all of you that since this webinar saga started, you have always supported us. You have always given us feedback. You have always given us questions. And perhaps that is what is pushing us even 5 years down the line. Just a couple of more questions before we go to the second part of the webinar. Dr. Manjunath?
Yes.
Possible complications of surgery and long-term prognosis of the surgery.
Very good question. One of the most severe complication is uncontrolled compensatory hyperhidrosis. Now, we have had patients where earlier what we used to do is technically we used to remove the nerve. A small segment of nerve was removed. So, if there is a compensatory hyperhidrosis, we have to actually reconstruct the nerve. The problem is it's at the level of high up in the neck, high up in the chest. The access is very difficult through the neck as well as through the chest. So uncontrolled compensatory hyperhidrosis was a major problem. Now we have done a modification in the technique. We don't cut the nerve anymore. We clip the nerve. So within 6 months, if the patient has severe compensatory hyperhidrosis, we can remove the clip, which is a very simple procedure, and we can reverse the problem. This is one of the most common complication, and this is a major modification in the surgical technique which has happened, which is really helpful in terms of treating compensatory hyperhidrosis. Other complications are gustatory hyperhidrosis. I have had one patient who is still having it, but he has come down on his spice level, so it is little better. More dry hands. Some patients complain, but I tell them that you had worst lifestyle before this, so you have to adjust to this one. Most of the most common complication, not a complication actually, as symptom which they tell me is they have hands are dry, but the soles are still little wet. When they tell me that, I tell them that it is still manageable because you can wear a socks and manage it. But if your hands are dry, we will not do any other procedure, and this is the maximum. This is the best we can do for you. And apart from that, you can have surgical complications like bleeding, pneumothorax, which are very rare. Wound infections are also very rare because there are only two 5 mm incisions to treat the procedure. The procedure is done just by two 5 mm incisions. So it's a very simple procedure in that case. Surgical complications are pretty less.
Thank you.
Yeah.
Dr. Nazia ma'am, as we were discussing that maybe everyone will not be able to go for surgery for various reasons. So when you have treated someone conservatively successfully, what may be the follow-up schedule and what do you tell the patient or attendant regarding risk of relapse?
Yeah. The first line of treating hyperhidrosis is topical. Aluminum chloride hexahydrate solution is used to decrease. It is used in night time, and they usually respond. But like sir has said, if it is excessive sweating and they are getting so much of sweat from the hands and they're not able to write, I advise the patient to go for botulinum toxin injections in the palms. It's a good procedure, and it responds up to 4 months. They'll not have no sweating on the hands, and definitely it's not like surgical things and complications. Up to 50 to 100 units of botulinum toxin is injection in the palms under topical anesthesia. It just takes 30 minutes for the injection, and they are free from sweat for 4 months for sure. But recurrence, the important thing is recurrence. They have to go for this procedure at least every 6 months till it sets on its own at the cortical and CNS level. They have to go for the several. I have several patients on this. They take both, even doctors, even dermatologists, they come with this hyperhidrosis of palms and soles, and we give botulinum toxin injection in the palms and as well as in the axilla. Tablets, when it comes to tablets, they come with certain complications like dry mouth, again constipation, and we have to be assessing the individual for that complications. I usually less prefer the tablets, but the thing is to go for botulinum toxin as it is easily available now, and we are going for this management. Iontophoresis once upon a time used to be done 3 times in a week, but again it's time taking. The patient has to get his own iontophoresis machine. So once an injection is taken once in 4 months, it is good to go.
Manjunath wants to contribute. You have raised your hand.
Yeah.
Please unmute.
Yeah. The problem I have with Botox is you have to repeat the procedure every 4 months, and the cost. For example, every Botox will cost somewhere from 25 to 50,000 each session I'm talking about. So it's like, how long are you going to do it? Like, it's not like, okay, 3 sessions I have done in a year, next year he'll be fine. He has to repeat it next year also.
Yes.
So, and the patient has to come so frequently that there is OPD visits, there is loss of hospital, there is loss of work, everything. So this is one of the issues with Botox I have.
Yeah, true. It's expensive. The injection is expensive.
We have reached to conclude the discussion on hyperhidrosis, and now I would want to invite Dr. Vijay Chennamchetty sir, who is our webinar coordinator, who would want to give us update regarding our this year activities and upcoming activities too. The stage is yours, Dr. Vijay.
Thank you, Dr. Manju. Thank you, Dr. Nazia. Okay, now, Atri Bhai, as usual, a wonderful moderation. Now it's time for we have to look back what CCI has contributed to academics in the form of webinars in the past 1 year. If you see, okay, the saga of the webinars which have started in the month of March to 2020. So till now, I think 2025 December, close to around 5.5 years. Okay, we are doing relentlessly, and kudos to the excellent team. Okay, of course, always Krishna Anna is the spark behind this such a huge successful program, and we can run for 1 kilometer, 5 kilometers, or 10 kilometers also we can run. But running a marathon is not an easy game. Okay, the motivation, inspiration, okay, of entire core CCI team is coming from none other than Krishnanna. Thank you, Krishnanna, for being such a wonderful spark of inspiration in pulmonologists across this subcontinent and beyond. And I must tell that okay, it's an honor to be part of CCI webinar coordinator, and then I learn a lot. If I want to do a pre-webinar Zoom meeting, okay, I have to read about the topic, what has to be incorporated, what has to be. That's how on personal front I am enjoying this a lot as a webinar coordinator of CCI. And thank you again, Krishna and the entire core team for such a wonderful opportunity. And in the past, in 2025, we have done close to around 60 webinars, out of which, okay, to be very precisely, I have become the course director for 2 webinars, that is COPD and ARDS. And then I must tell, as a take home, if in 2025 you want to take home back what you have learned from COPD webinars is very, very clear. My dear friends, I have coined a term called precise. Okay, what is precise way of managing COPD in 2025 as per 2026 gold guidelines is? So please always look for what phenotype we are managing. Okay, and so like, are we handling with a exacerbator? Are we handling with a asthma COPD overlap? Am I managing emphysema? Is this patient is going to require triple therapy, which has become in the past 2 years based on ethos and impact trial? There's a huge discussion that has happened, which patients are going to benefit from the triple therapy. So always remember precise, that is as per the evidence-based management is very important. We have to always focus on PR, risk reduction. What is risk reduction means? So if your COPD patient taking triple therapy or lava therapy along with the smoking as well, please ensure to catch hold of him and then counsel him for smoking cessation. If he is not got vaccinated, ensure that okay, vaccination is done. The biggest mortality impact intervention in COPD is cutting down the risk reduction. Escalate with evidence. All this LAMA or those patients who are getting only LAMA or LABA plus ICS, if they belong to the triple therapy category, as per again, I have mentioned ethos, impact and tribute trials, ensure that you put the patient on triple therapy, because first time in the past 2 years, it is very clearly known that, okay, even pharmacology therapy, like triple therapy, is going to impact the mortality reduction. So that's why mortality reduction, to reduce mortality, put the patients on triple therapy who are the perfect candidates for triple therapy. And then comorbidities. I have a fortune to moderate the syndemic approach of management of COPD. That means associated comorbidities like coronary artery disease, heart failure, obstructive sleep apnea, osteoporosis, sarcopenia, GERD. All these have to be identified and managed better. And I means inhaler therapy. Whether this patient is going to benefit from a dry powder inhaler or a meter dose inhaler or nebulized form of therapy, it is very, very important. As a pulmonologist, you should identify which kind of inhaler is going to be better for your patient, and involve the patients, empower your patients. That is self-management of COPD. So enroll them, motivate them to enroll into pulmonary rehabilitation. So again, pulmonary rehabilitation is going to cut down the hospitalization rate, is going to decrease the mortality to some extent, and it is going to improve the quality of life. And last E in the precise, so end stage and ethical approach, if you see. So what happens is, so when the patient is nearing, okay, the FE1s of around 15%, 20% with recurrent exacerbation, these are the patients we should try to manage, integrate palliative care, and then if they are right candidates, enroll them into transplant programs, and that's how we should precisely in 2025 end or 2026 we should manage. Again, to repeat, P means phenotype identification, R means risk reduction, E means escalation with evidence to triple therapy, C means comorbidities identify and better, I means proper inhaler technique, S means empower the patient with self-management, and end stage and empathetic approach is very, very essential. And the other thing which I was fortunate enough to become, to be the course director is ARDS webinars. Okay, in ARDS, again, to be very, we have to excel the ARDS, and now the mnemonic is EXCEL, EXCEL, which means early recognition of ARDS is very, very important. So time lost means lung lost. So improper management during early ARDS leads to improper management of overall ARDS, and then advanced ARDS leading to losing of lives, and then approximately close to around 30% of patients, they may lose their lives. So early identification is very, very important. Exact lung protective ventilation. That means a tidal volume of 6 ml per kg body weight, low tidal volume ventilation, and always keep the plateau pressures while ventilating to less than 30 centimeters of water. So this is from the ArtsNet, age-old, probably 2 decades back trial. But this is the one thing, the rule of thumb. The mortality is reduced by using lung protective ventilation. Then conservative fluid strategy is again as per the fact trial. It is going to decrease the number of days that patient will be on ventilator. So that thereby improving the outcomes. Then escalation ladder. So whenever the patient is not getting better on mechanical ventilation, P plateaus tend to rise, and hypoxia, to make the hypoxia better, make them prone ventilation, and then in some cases you can use neuromuscular blockade, but whomever you put them on prone ventilation, neuromuscular blockade is very, very important, and this prone ventilation should be at least minimum 16 to 18 hours per day. And then in refractory hypoxemia, those who doesn't respond to prone ventilation, it is very important to consider ECMO at the earliest. ECMO is not the last resort, my dear friends, please remember. So early initiation of ECMO is going to save lives. And again, that is based on robust data from PROSIVA trial and EOLIA trials. And limited ventilation induced lung injury. So as I mentioned again, driving pressure focus, avoid over distension and atelectative trauma, and emerging evidence says driving pressure is strongest mortality predictor. So it is very, very important. Again, just to repeat the mnemonic, E means early recognition, X means exact lung protective ventilation, conservative fluids, escalate the ladder to prone ventilation with neuromuscular blockade, and if it is failing, early conversion to ECMO is very, very important, and limit the ventilation-induced lung injury. These are the key steps that we should follow and manage the ARDS. And to what we are going to plan in next 2026. Yes, Atri Bhai has said already, we have a robust CCI National Conference that is scheduled in September month, Guwahati. So please make your time, and then for the sake of best networking, for the sake of very good academics, please stay tuned to Guwahati National Conference, and then we are going to have another 60 webinars completely packed. We are not repeating any of the exact content of the webinar. So more than 300 to 350 national faculty are participating in these webinars. Make best use of CCI webinars. Over to Atri Bhai.
Play.
Hello everyone, my name is Dr. Kapil Iyer, CCI. I don't even know yaar, मैं कहाँ पे begin करूँ और मैं क्या बोलूँ, but CCI has been churning out academic webinars year after year after year. I always open my webinars by saying Thursday की रात CCI के साथ. I always do this. And it's not an easy job. But for me, the one special thing was that 2025 mein, there was a dedicated webinar series for lung transplantation. It's something which I'm really passionate about, and never before has this happened. I was privileged enough to be one of the course directors for this webinar series dedicated to lung transplantation alongside Dr. Apar. Now, what exactly encompassed this entire series? We spoke about referral patterns. We spoke about ground realities of lung transplantation in India. We spoke about airway complications. Why does it happen? What is the need? How to intervene? When to intervene? We spoke about a very, very interesting and important topic, which is infections in the peri-transplant period. I firmly believe that in India, it's not rejection, but it is infection, which unfortunately is the number one killer post-lung transplantation. We also spoke about rejection. And remember, we did not only talk about the types of rejection, clinical aspects, how to manage them, but we also had a dedicated transplant pathological perspective of rejection. We also spoke about immunosuppression, what are the long-term side effects, what is the best regimen, and how to choose this tailored for our population. And according to me, the most, the icing on the cake was the financial aspect of lung transplantation. This has never been covered in India, and I doubt whether this will be covered in the near future. But thanks to CCI, we actually spoke about the financial dealings of lung transplantation. Now, the moderators and the panelists were a mixture of experienced transplant pulmonologists who have just finished their training in lung transplantation. We had transplant pathologists. We had general pulmonologists also who were seniors as well as juniors. So really, it was a complete mixture. And believe me, I firmly say that if anyone is interested in lung transplantation, just to know about the basics, I think this 6 webinar series of lung transplantation should be the go-to platform. Really thank you to Krishna sir, Narayan Pradeep sir, Dr. Vijay Kumar, Chennamchetty Garu, Atri, Ravi Dosi, Shivani, Kira. There are so many names. Special thanks to Dr. Apar, who was also one of my course co-directors, and I was privileged enough, as I mentioned before, to being given this opportunity of being a course director. Thank you so much, CCI, for all of this. Thank you so much.
Good evening, everybody. So since we are doing this as a concluding series for the year 2025, we are highlighting the series that we've done with CCI. So we did a very successful sleep webinar series over 5 webinars. This was probably the first of its kind sleep webinar series that was done in the country, at least as far as I know. We commenced this series on the 9th of December, and we covered over 5 webinars. We covered basic topics like sleep physiology, moving to diagnostics, then pediatric, obstructive sleep apnea, sleep-related breathing disorders, and eventually parasomnias, which is much less talked about. The webinar series was a huge success, getting thousands of logins every week over the 5 webinars. And I am extremely thankful to all the moderators and panelists of the webinar series, without whom we could not have concluded the successfully done webinar series, which still continues to fetch thousands of views on the YouTube CCI channel. Of course, the idea was, as always, originated from our founder, chairperson, Dr. N.H. Krishna sir. We are also very thankful to Dr. Narayana Pradeep, Dr. Ashish Dubey, Dr. Anil Maske, Dr. Vijay Kumar Chennamchetty, Dr. Atri, Dr. Kirat, and last but not the least, my sleep webinar co-coordinator, Dr. Ravi Dosi, who was always leading from the front. And every morning, I think I would wake up to his messages for new ideas on the webinar series. So thank you, everybody at CCI, for giving us the opportunity to do the series extremely well. We look forward to adding more webinars to the sleep series in the future. Thank you.
Hello, friends. My name is Dr. Dhar, and I head the Department of Pulmonology at the CMRI hospitals in Kolkata. Merry Christmas to all of you. I hope you're having a fantastic friend. And greetings to all my friends in the Chest Council of India. I'm sure you're in the middle of a very exciting webinar, ones that only CCI is capable of doing. I have come with a very pleasurable task on this auspicious day. I'm here to talk to you about CCI Con 2025, which concluded in Kolkata not so long ago. Let me show you some glimpses of the conference while I talk a little bit for about 3 or 4 minutes about the conference itself. So CCI Con Kolkata happened between 22nd to 24th of August 2025. First of all, I would like to thank Dr. Krishna and the CCI Governing Council for giving me the honor of hosting this conference in our city of joy. The conference, which was the 6th National Conference of CCI, happened in ITC Royal Bengal, which is a majestic venue in the vibrant city of Kolkata. We started off on day 1 with multiple workshops, which happened in different hospitals across the city. We were privileged to have a very large attendance for these workshops, as also the inaugural ceremony, the glimpses of which you're seeing on your laptop or your phone at the moment. We were again lucky, very happy to have as many as 900 delegates registering for the conference, and at any given point of time, we had more than 600, 650 people at the venue. The program was carefully curated with a lot of help from distinguished faculty within CCI. It was curated for youngsters and also for the experienced pulmonologist, and I hope all of you who attend the conference manage to get something out of it. I think I'm right in saying that the scientific program was well structured, and also thanking the faculty for their spontaneous and passionate participation. This was evidenced by the number of people who were in the halls at all times throughout the conference. Let me show you some more photographs from the conference. So you can see the various areas of the conference as I go through the delegate registration booth. We were fortunate to have Mr. Boria Muzumdar as one of the chief guests for the inaugural ceremony. I'm also very thankful to Dr. Indranil Haldar, who was the organizing secretary for the conference. I show you a glimpse of the packed halls, the youngsters, my team at CMRI, who was there spontaneously and without whom the conference would never have happened, and the very senior esteemed faculty that you see at the bottom, whose presence was a blessing for all of us. The heart behind the conference, as always, was Dr. N.H. Krishna. He was also one of the keynote speakers and spoke on a unique topic about relationships, friendship, and leadership. These are areas which are his forte, his area of expertise, without which CCI could never have been built up. And my friend and senior colleague, Dr. Rakesh Chawla, was the other keynote speaker on the same day. So these are glimpses of the various aspects of the conference. The organizing committee is very thankful to all of you for participating the way you did in the conference. We have, of course, been enriched by the exchanges that were offered during the conference. We hope to host all of you again, CCI again, in some form or the other in future conferences in our vibrant city, and I'm sure we'll interact on many platforms. Going forward, we look forward to another CCI Con in the eastern part of the country, which will be in the city of Guwahati, the lovely city of Guwahati, and I hope Dr. Kripesh Sarmah, who is the organizing chairman for this conference, will do a conference which will exceed what we did in Kolkata. All the very best to CCI, Team CCI, you guys rock. You're wonderful, and I'm fortunate to be a part of the CCI team. I wish all of you the very best for the new year 2026. I hope all your dreams are fulfilled. I hope you have a successful year, both on a professional and a personal front. Thank you very, very much, and look forward to seeing you again soon.
Respected all, CCI had brought its lung webinar series in 2025, which was immensely appreciated by a lot of its CCI members who attend webinars regularly, the tune of exceeding 1500 per webinar, and there were 10 parts of this particular webinar series, of which several pulmonologists of international and national repute, several medical oncologists, radiotherapists were members, and even radiologists, interventional pulmonologists were included in several of the 10 webinars which dealt from diagnosis to interventional pulmonology to guideline changes which have been happening in the field of medical oncology to assist our members to be up to date with the whole process of lung cancer diagnosis, treatment and follow-up. So CCI has really tried hard to bring an update on lung cancer in 2025. With future years, definitely it will be trying to bring you more such updates. The lung cancer webinar series was very well accepted, and it was moderated by CCI Life members who have acclaimed national repute and are actually providing you with data which is practice changing and practice upgrading. Thank you very much. Have a happy new year 2026.
Good afternoon, everyone. So I am Dr. Kripesh Ranjan Sarmah, and already you have learned lots of academic activity in Chess Council of India Annual Conference, that is CCI Con, recently held in Kolkata. So next CCI Con 2026 will be held in Guwahati, and we are happy to welcome you. The CCI Con is always a center of academic excellence, where newer learning process has always begun with lots of hands-on experience. Workshop also has been planned. So hopefully we will see you, all of you, in CCI Con 2026 in Guwahati. Please block our date and don't miss this academic event. all the team of CCI Con present in Northeast will be happy to welcome you all. Thank you.
Thank you, my fellow speakers. Dear friends who are watching us, all the people featured in this video, they are larger than life. They are not only Indian celebrities, they are international celebrities. Despite their busy schedule, they always take out time for CCI, for which we are very grateful to all of you. And I request the people watching the video, if you are a CCI member, please take out time for CCI, be part of our webinars, be part of our physical conferences. If you're not a CCI Life member, please become a CCI Life member. I'm very grateful to Dr. Narayana Pradeep, Dr. N.H. Krishna, who are the founder trustees of this organization. They are very effective. They are still very active in choosing this webinar topic, choosing the people. We have been able to debut 45 people in the last year in our webinars. That's a wonderful number. We always believe in giving new people the chance that if you want a stage, we will give you the first stage in your life. If you are a CCI Life member and yet not featured in a webinar, I apologize in advance to you. Please message in your respective groups and we shall definitely give you a chance in future webinars. Few people were not part of today's webinar due to various reasons. Dr. Agam Vora sir, Dr. Kirat Kaur Sipia, they are also part of our planning team to ensure that the best programs reach you. And the 60 webinars which we did in the last year had a combined reaction or live login over 1 lakh. That is 1800 plus average live logins per webinar. We shall continue with giving you new knowledge because the core principle of Chess Council of India is there has to be no compromise with respect to academics. And only by encouraging unbiased academics can we grow, can we help you grow. I want to acknowledge the sponsor for today, Mankind. Thank you. Academic partners are very essential in disseminating academics. And definitely, I want to wish all of you a wonderful Merry Christmas, a wonderful New Year 2026. Please be part of our webinars and do please attend the CCI Con Guwahati. Mark your dates for September. So from all of us here, we wish you good night, good evening, good afternoon. Thank you.